I think this talk is probably a nice follow-up to the live case we've just seen today in the morning, the first one from Leipzig, where we in fact could see how, which challenges occur when we deal with really long, challenging femoral popliteal occlusion. Well, one of the first discussion points when we start treating those patients is, of course, the Guidewire Passage. And here, I think it has been, at least in the last year, is almost a philosophical discussion whether the intraluminal or the subintimal approach is the better one. I think years back, there are operators like Dr. Bolia who very much advocated a primary subintimal crossing, whereas probably most operators tried, if possible, to stay as much as possible intraluminally. Well, in fact, there are probably no data to compare really these approaches. The best I could find is actually this study by Dr. Soga from Japan, who looked at the initial and 3-year results after subintimal versus intraluminal approach, and he checked with external or intravascular ultrasound whether he was intraluminally or subintimally. And basically you can see here how this compares. Basically he also stented all of the patients, so you can see that the success rate was very similar. He crossed more patients intraluminally as compared to subintimal. The procedural time was clearly much shorter for the subintimal crossing, but overall the 3-year primary patency rates, as you can see, were identical. So in a way, he concluded then that probably the subintimal approach is the preferable one because it's just quicker and otherwise compares very favorably in terms of the outcome. Well, I think we have to, of course, say, even though that he controlled patients with ultrasound, I think still there were cases described that the Guidewire was partially subintimal when it was intended to be intraluminal and vice versa. And I think probably since this analysis was only done on intention to treat basis, we still probably can't be sure, as we all know, whether really the lesions were crossed intraluminally or subintimally. Well, anyway, I think it is very reasonable, particularly for short lesions, even if they are very calcified, like in this case, to try to cross a lesion in the true lumen. What we typically use for these crossings are 018 CTO guide wires, like the Connect 250T, for instance. We do shape only the very first millimeter of the tip, and then with the help of a support catheter or a balloon, like in this case, we try to attempt the crossing. Well, I think even if you try to cross in the intraluminal space, I think we all know that not always it works out, and it's probably occurring in about 20 to 30% of the cases that your guide wire gets stuck somewhere in the subintimal space, and then you have difficulties to re-enter. The problem if you do more attempts, then you may re-enter, but sometimes you are going across collaterals, and then with ballooning and maybe even stenting, these collaterals will be blocked, and so that may be not the ideal scenario. To avoid this, of course, we have reentry devices available, which are highly effective to re-enter back into the intraluminal space. The disadvantage is that they are, of course, costly and technically a bit complex. And also, not always the reentry device is really able to achieve the reentry in a very discrete point, which would be desirable here to stay above this collateral branch. Sometimes, as you know, you have to also look for a good place to penetrate with a needle, which means that sometimes you have to move the reentry device further down, and then again you run a risk that you block the collateral after the dilatation and stenting. And this is one of the reasons why in our lab we use quite frequently a retrograde approach, which basically enables us to be very precise and stay above such collaterals, and then of course also to avoid the cost of the reentry device. So if it comes to retrograde approaches, the standard approach would be to come from the popliteal, which allows the insertion of a 4 to 6 French sheath. Typically, the patient is turned into a prone position, which is at the end of the day not very convenient for the patient during lengthy procedures, also not for the physician, and it also limits, for instance, the ability to have a bidirectional access, because then if the patient lies in the prone position, you have very big difficulties to access a sheath in the groin if you want to have a secondary access. That's why we typically do, as you could see in the case Andre showed live, to puncture to keep the patient in the supine position and puncture basically from the front into the distal patent segment of a superficial artery, or even the first popliteal segment. So here again, it is shown how we position the entry point of the needle. Basically, the upper margin of the patella serves as a reference, and then you can see here the local anesthesia carried out. And then we typically look for an oblique projection to make sure we bring the needle in one plane with the artery and do the puncture. What kind of needles are used? 21 gauge needles are the standard. They are available in 7 and 9 centimeter length. So typically for this puncture, a 7 centimeter needle is preferable. Sometimes if the patient has a very big thigh, a 15 centimeter needle may be nice to use. The problem is this becomes relatively floppy, and what we can do is that we actually use this 15 centimeter 21 gauge needle through an 18 gauge 7 centimeter needle in a coaxial kind of telescoping technique, which gives just more stability to the needle. So you can see here the puncture attempt. Again, we typically use fluoroscopic guidance. You see here in this case, typically a left for the right thigh, LAO 45 degree projection is probably right. You can see here it's important the needle and the artery have to be in one line. And then when we think we are deep enough in, typically it takes the whole length of the needle to be really deep enough in. Then we basically go to the 90 degree oblique projection to check the depth of the needle. You can also see here the angulation, which is probably optimal. And then really for the final millimeters, we go back to the original projection. You can see here almost the imprint into the artery when the needle hits the vessel. Then a V18 wire, typically we use 018 wires for these access. You can see here that in this case the wire didn't want to come out of the artery. So here it's good to go back to the 90 degree oblique projection, because a frequent scenario is that you have punctured a little bit through the artery. That also happens very frequently when you do tibial accesses, and I think you should not give up the access. You rather pull back gently and then insert the wire in this lateral projection. What's next? You could see already in the case, typically we just like to use the sheathless approach with the help of support catheters to really use this retrograde access only for crossing. If a sheath insertion becomes necessary, I think a 4 French pediatric sheath is a good option with a 10 centimeter length, which works over an 025 needle, so over 025 guide wire, so you can easily use it over an 018 guide wire. Which is useful if you have to do a retrograde ballooning, for instance. Then after crossing, you can see here again the snaring maneuver. We use these angulated catheters, typically a right Judkins catheter, just to externalize the wire coming from retrograde, and then basically insert the balloon in an antegrade way. How to achieve hemostasis? Well, typically we just do hand compression for 5 minutes. In some cases, Placing a blood pressure cuff can be helpful if really there's a little bit prolonged bleeding. And you can put a balloon across the puncture site. Also, I must say that we primarily rely on the external compression. You can see here as a result after the recanalization, a little bit spasm here at the puncture site, which is not infrequently seen. Otherwise, at the end, you always have the ability to check for the completeness of the hemostasis. So what if the retrograde crossing fails? You could see that the first step would be the antegrade balloon dilatation, so-called CART technique, just to lacerate the membrane and to create an entry point for the retrograde wire, or if that doesn't work, double balloon dilatation, also as seen in the case. And then finally, PK mentioned during the case the technique of coming antegrade with a reentry system and having a retrograde balloon in place, kind of to create a target for the needle of the reentry system. That's also a nice alternative if really the other techniques do not work. Just about results, we analyzed some years back our first 50 cases where we used this retrograde approach. We actually had a success in 48 out of 50, and 2 small aneurysms were actually observed. So I think with that, I stop this talk. Thank you.